Hello, and welcome to today's webinar, Emergencies in Colorectal Surgery, hosted by the International Relations Committee and the ACS Thailand chapter. My name is Jessie Romans, and I am a committee administrator for the International Relations Committee. I am happy to introduce to you today's moderator, Dr. Art Hiranyakis. Dr. Hiranyakis is an experienced academic colorectal surgeon. He is the director of the Bangkok Phuket Colorectal Disease Institute Center of Excellence. He's also a governor at large and president of the Thailand chapter at the American College of Surgeons. He's recently been selected as the Assistant Federation Secretary of the International College of Surgeons Pacific Federation. Dr. Hiranyakis also participates on editorial boards and is a reviewer for many peer-reviewed, high-impact factor international journals in colorectal surgery. He has regularly directed and organized the biannual world-renowned International Colorectal Disease Symposium that has taken place in Phuket and Bangkok since 2013. With that, I'll now turn it over to you, Dr. Hiranyakis. Dr. Hiranyakis.
Thank you, everybody. Thank you, Jessie. Thank you for your kind introductions. So, yeah, the next step would be for me to introduce our distinguished speakers today. We have two female colorectal surgeons, which are the rising stars at the moment. They're all my friends. And it's my pleasure to first welcome Dr. Emanuela Silva Alvarenga. Dr. Alvarenga earned her medical degree at the Faculty of Medicine, Judai University in Sao Paulo, Brazil, where she also completed her general surgery and coloproctology residencies. In the US, she retrained and accomplished her general surgery residency at the Florida State University, colorectal surgery residency at the Cleveland Clinic, Florida in Weston. She is board certified by the American College of Surgeons and the American Board of Colorectal Surgery. Prior to joining Cleveland Clinic Modern Health, Dr. Alvarenga was a colorectal surgeon, clinical associate at the Cleveland Clinic, Florida, faculty member with Rose University School of Medicine. She's also on the faculty of the Florida State University College of Medicine. He holds professional memberships in American College of Surgeons, the American Society of Colon and Rectal Surgeons, the Society of American Gastrointestinal and Endoscopic Surgeons, and the Brazilian Society of Coloproctology. Please welcome Dr. Alvarenga.
Thank you, Art. Thank you. All right. Should I share my screen now? Okay. Thank you for a very kind introduction, and it's a pleasure for me to be here today with you and Dr. Boutros. I'm going to talk a little bit about emergencies in colorectal cancer. I have no disclosures. Despite the introduction of colorectal cancer screening programs in many countries, up to 30% presents as an emergency. A significant proportion of these patients have worse short and long-term outcomes compared to elective presentations, even after adjusted for T&M stage, with high perioperative mortality rates between 12 to 30%. The most recognized factors associated with emergency presentations are ASA status and tumor stage. This recent meta-analysis of 54 studies from the past 3 decades, including pre- and post-screening era, showed that emergency presentations were associated with ASA 3 category and more advanced tumor stage, both overall and T&M subclassifications, as well as with presence of lymphovascular, vascular, and perineural invasions. In addition, they also found emergencies were more likely to be of ethnic minority. There is recent research suggesting that emergency presentation itself is an independent poor prognostic factor. Indeed, we recommend to consider adjuvant chemotherapy for stage 2 cancers. However, it might be a combination of this and other factors such as body composition rather than an emergency per se. And I think I passed one slide too quick. Apologize for that. One in 5 newly diagnosed cancers present emergently as an obstruction, as a perforation or bleeding, most commonly as obstruction followed by perforation, and many times with both conditions. 75 of these tumors are located distal to the splenic flexure, and the most common location of obstruction is in the sigmoid colon. Perforations happen at the tumor site in 70% and 30% proximally to the tumor, which makes a systematic assessment of the entire colon imperative during surgery. And while chronic anemia due to low volume bleeding is common in these patients, significant bleeding requiring emergent operation is quite uncommon. And although the management should be tailored to the nature of the presentation, the clinical decision-making and the treatment planning must stabilize the patient, either sepsis or bleeding, then attempt to achieve optimal oncologic control. To maximize the opportunities for the additional oncologic treatment, starting with stabilizing the patient whenever possible with IV fluids resuscitation, correction of hypovolemia, electrolyte derangements, coagulopathy, pH disturbances, and anemia. Control of sepsis with broad-spectrum IV antibiotic prophylaxis targeting gram-negative bacilli and aerobic for potential bacterial translocation are also recommended. In patients with bowel obstruction, nasogastric tube decompression might be of a benefit if incompetent ileocecal valve. And asserting the ileocecal valve competence earlier in the process is essential, as these patients can quickly progress to closed-loop bowel obstruction. If clinical status allows, completion staging with CAT scan of chest, abdomen, pelvis, and CEA levels with MRI of the rectum if it's a rectal cancer would help determining prognosis and the goals of care. Additionally, stoma marking and education is encouraged when chance, and especially when anticipating a permanent stoma. Even though the pathophysiology of colonic emergencies can be alarming, the principles of surgical management remain relatively straightforward. For stable patients, endoscopic or surgical decompression can and should be contemplated. A patient in extremes or who did not improve with resuscitative measures needs exploration, and patients with perforation or impending perforation need surgical resection. And although the intraoperative decision on extent of resection and type of diversion, if diverting, or an intestinal bypass, might be mainly dictated by patient's prognosis and goals of care, several other factors will play an important role in the surgical plan, as we will discuss in the next few slides. But regardless of the strategy in the operating room, the oncological principles must be followed, including assessment, documentation of metastatic disease, adequate 5-centimeter margins should be guaranteed whenever chance and feasibility if the lesion is deemed to be resectable, with high ligations of vessels to ensure proper lymphadenectomy, as well as unblock resection when indicated. For the acute left-sided malignant colonic obstruction, there's been a lot of evolution in the approach for the past 3 decades. For the management of curable acute colonic obstructions, current research shows that decompression with endoscopic stent or diverting loop or diverting ostomy are both effective methods. In the most recent guidelines from the American College of Surgeons states that decompression with interval colectomy are generally preferable to emergent colectomy. Endoscopic placement of a self-metallic stent as a bridge to surgery has been available for over 10 years with multiple published advantages, including ability to convert an emergency surgery into an elective one with decreased pre-op morbid mortality, increased oncologic staging, possibility of colonic preparation, promoting minimally invasive approaches, quicker initiation of chemotherapy, and lower rates of creation. However, its superiority as a bridge to surgery is still debated. There are concerns for delayed adverse events of reobstruction, migration, and perforation that might be occurring during placement with possible neoplastic spread and negative impact on prognosis. This is a network meta-analysis, but published last year from 1,277 citations, including 55 studies, comparing patients undergoing urgent oncologic resection, surgical resection, and stenting. As you see here, there was no study directly comparing surgical diversion and stents. The study demonstrated significant improvement on the 90-day post-op morbidity in patients undergoing stent comparing to urgent resections. There were insufficient data, randomized data for analysis of overall survival, and the analysis showed decreased 5-year overall survival on patients undergoing resection versus stenting placement. This is a large meta-analysis also from last year, including 19 randomized controlled trials from 4 major databases. There was no significant difference in 30-day mortality between stents and surgical resection. And although there were numerous short-term advantages as listed here, the stent group had a statistically significant higher overall tumor recurrence rate. On the role of diversion for the left-sided obstruction, the patients who are hemodynamically unstable during surgery or medically frail should undergo colostomy. And in the presence of carcinomatosis, resection should be deferred and the proximal diversion performed. The downside of this approach is that the tumor is not resected at the time of the surgery, and several studies have shown equivalent outcomes between these patients undergoing the functioning ostomy alone compared to the primary resection. In randomized controlled trial comparing the functioning loop colostomy and primary resection reported no significant differences in terms of morbidity and overall survival between the two approaches. And these findings have been endorsed by Cochrane systematic review. So one could advocate for oncologic resection when feasible, reserving loop colostomies for very frail patients when prompt palliative procedure is required, or in those with unresectable disease. In patients with large obstructing rectal tumors, the recommendation is diverting at the index operation so that the patient can undergo adjuvant therapy and undergo later on a TME resection. Emergent operations should be avoided if possible due to higher risks of suboptimal surgical resection leading to poor oncological outcomes. Multiple prospective series have shown that primary resection with anastomosis for the left malignancy can be performed with anastomotic rates ranging from 2 to 12%, which is not too different from the leak rates after elective surgery. The caveat is that no randomized controlled trials are naturally subject to confounding biases. So surgeons are more likely to perform anastomosis in favorable situations with no contamination, healthy tissue, good blood supply, stable patients, and more likely to divert when in unfavorable scenarios. And because the consequences of anastomotic leak can be devastating with life-threatening sepsis and inability to proceed with adjuvant chemotherapy in a timely fashion, risk stratification and clinical judgment are crucial. Subtotal colectomies with iliosigmoid anastomosis or total colectomy with iliorectal anastomosis are the options in the presence of proximal colonic ischemia, cecal perforation, serosal tearing, not amenable to primary repair, or synchronous lesions. In multiple case series reported outcomes after total colectomy and anastomosis, with anastomotic leak and mortality rates from 0 to 10 in both cases. And one main concern for this approach is the functional. After a total colectomy, with ileorectal anastomosis comparing segmental colectomy. This concern had been shown and addressed by the Scotia trial, where they randomized 91 patients with large bowel obstruction to either segmental colectomy or subtotal colectomy. There were no significant difference in anastomotic leak or overall mortality rates. However, in patients with the subtotal colectomy group, were significantly more likely to report increased bowel function. Differently from the left side obstruction, resection with primary anastomosis have been usually performed on the right side of the colon because of its ease and because of its relatively low risk of anastomotic complications. However, some contemporary studies have also suggested that morbidity of proximal obstructing lesions might be underestimated. This author reported a prospective audit in 776 patients with right malignant large bowel obstruction, where 90 to 82% underwent anastomosis with high post-mortality and leak rates. And these results have been replicated by other authors. Biondo and al. Also published higher mortality rates when anastomotic leaks occurred from right anastomosis compared to leaks on the left side. And while most of the patients will do well with resection and anastomosis, there's really no robust data that to guide us regarding which patient might be better served with resection with some sort of stoma, and the decision is left to the surgeon's discretion and intraoperative judgment. On the rare cases where large volume lower GI bleed from colorectal cancer occurs, the initial approach should be just like any other significant GI bleed. And current guidelines from the American College of Surgery, colorectal surgery, recommends no surgical approach when possible. And in cases of persistent bleeding, surgical oncologic resection is recommended. In cases of rectal bleeding, consideration should be given to prompt initiation of radiotherapy to stop the bleeding. And in the setting of perforation or impending perforation of the colon, expedited oncologic surgery with low threshold for performing staged procedure is recommended to address diffuse peritonitis and septic shock which can quickly progress to multi-organ failure. So in summary, although the physiopathologies of colon emergencies can be nuanced depending on its nature, they all share the same key concepts. In all situations, the clinical decision-making and treatment planning must include resuscitation, stabilization of the problem, either sepsis or bleeding, while achieving or aiming to achieve optimal oncological control and to allow for adjuvant oncological treatment and to promote quality of care. Thank you all.
Thank you. Thank you very much, Dr. Veronica, for such an comprehensive and excellent talks as always. Thank you. So if there is any question from the audience, please feel free to put all your questions in Q&A box below. So let me introduce our next speaker. I now welcome Dr. Mary-Lise Boutros. Dr. Boutros is staff colorectal surgeon at the Cleveland Clinic, Florida, and the Regional Digestive Disease Institute Director of Research. Previously, Dr. Boutros was a colorectal surgeon at the Jewish General Hospital, professor of surgery and colorectal surgery program director at McGill University, Canada. Having completed general surgery residencies at McGill University and colorectal surgery residency at Cleveland Clinic, Florida. Her clinical interests are advanced minimally invasive approaches to benign and malignant colorectal and anorectal diseases. Dr. Boutros is a federally funded researcher who currently leads an internationally renowned research program focused on assessing innovations to improve recovery and functional outcome after colorectal surgery using multi-center prospective trials. Within her research program, Dr. Boutros has mentored over 40 trainees and graduate students. Dr. Boutros also has leadership roles in multiple international societies, including Society of American Gastrointestinal and Endoscopic Surgeons, American Society of Colorectal Surgeons, Canadian Society of Colorectal Surgeons, and the Canadian Association of General Surgeons. Please welcome Dr. Boutros.
Thank you very much, Dr. Heranyakis. It's a real pleasure to be here with you all today and to talk about a topic that I love. Let me make sure I'm sharing correctly. Is my sharing proper, Jesse? All right. Well, thank you very much, Art, for the invitation. And it's nice. I was looking at the group of people here. I recognize a lot of names. So thank you for joining us and for all who will watch this afterward. I was tasked with diverticulitis, and I decided to focus on primary anastomosis versus a Hartmann's resection, because that's, I think, something we often think about as we're consulted in the emergency setting for this disease. My only disclosure is a speaking honorarium for teaching colorectal boot camp by Ethicon Johnson & Johnson, and it's not related to this talk. So many times we're on call, we hear about a patient who has diverticulitis, peritonitis, and CT findings. And as you're walking over to see that patient, I'm usually thinking about, am I going to do this open? Am I going to do this lap? Am I going to do a Hartmann's? Am I going to finally do a primary resection and anastomosis? We keep talking about it, but I'm not so eager to do it all the time. And these are some of the things I'm thinking about as I approach the patient. Over the last 2 decades, there's been a lot of talk about can we avoid the Hartmann's procedure? We all like it. The Hartmann's procedure is the gold standard. When it comes to perforated diverticulitis, it's a safe operation. You just take out the hole, you come back and fight another day once the patient is better. Of course, a lower risk of leak. It's a shorter operation. Often we're operating in the middle of the night. Versus there's a lot of literature accumulating about the superiority of primary anastomosis in terms of being able to close stomas, and that it is feasible in purulent peritonitis and even feculent peritonitis. So, am I being an old dinosaur by not thinking about adopting primary anastomosis? And I kind of question, as we hear about all this data, is the Hartmann's becoming obsolete? Certainly in the practice that I came from, it was not obsolete. It was, when you round after a night of call, there's Hartmann's on the ward. People are still doing a Hartmann's. And so I kind of had a second and more detailed look at the literature to see, who were these people in these trials? How sick were these patients indeed? Are they similar to the patients that I'm seeing on call? And what kind of operations were done? And what were the outcomes exactly? And so I keep asking myself, the literature is accumulating with data. And I would say for about 2 decades now, we've had a plethora of retrospective and single center prospective cohorts published saying you can do a primary resection anastomosis in perforated diverticulitis, and then they compare it retrospectively to patients who had a Hartman's, and immediately we all say, well, this is selection bias. The patients who are sicker will get a Hartman's, and that's why you have better outcomes when you look at primary anastomosis. People have meta-analyzed this data, and of course, the selection bias continues, and you see better overall outcomes when you do a primary anastomosis, likely because those patients are a little less sick. Remember, diverticulitis is such a heterogeneous disease, and this might be hard to capture with the quality of this data. But are there randomized controlled trials? And so there are several out there, and this is a very hard topic to study in a randomized controlled trial. It's an emergency operation, it's life-threatening, it's happening in the middle of the night most often. So the first group came from Europe, and this was a randomized controlled trial that went over a 9-year period at 14 centers. This is a huge tour de force. They had hoped to recruit over 300 patients for a sample size calculation of a 10% difference in morbidity. However, they had to stop after 9 years due to slow accrual. Very hard a study to accrue for. What did we kind of learn from their experience? That the grand majority of patients that they were able to recruit to the study were Hinchey 3. So already the patients being entered into the study are highly selective. We're talking about 9 years, 14 centers, only 90 patients. So surgeons are very highly selective in who they will enter into such a trial. So we need to remember that when we're thinking about, the patient we're seeing at night. 50% had localized peritonitis, not even generalized peritonitis, and the grand majority, of course, were purulent peritonitis, not feculent. When you look at their data a little closer, what do we see? We see that even forget the p-value because they stopped the study early. But if you look at night, you're more likely, if you're performing night surgery, which I really love that they reported, you're going to be more likely to do a Hartman's, right? I don't know how it is in the rest of the world, and we'll chat in a few minutes. But, if you're going to tell the nursing team and anesthesia that you're going to start doing this formal operation that you need to do for a primary resection and anastomosis in the middle of the night and get the laparoscope out too, you're not going to make many friends. And we'll talk a little bit more about that. The very grand majority were open surgery. And because you need to mobilize the splenic flexure, often for a primary section anastomosis, there was more splenic injury. Of course, not statistically significant, but a 3% splenic injury rate. We need to be cognizant of that. When you look at their results, they had an overall mortality of 10% in the Hartman's group. So there must be some selection bias still happening here, even though it was randomized, but such a small number. So probably chance has not, made the confounders equivalent in both arms yet. Overall, a low anastomotic leak rate, which is reassuring. And they found that the main predictor for mortality was preoperative organ dysfunction, which makes sense, not the operation itself. So then our colleagues in Switzerland put together another randomized controlled trial. This was published in Annals of Surgery, 136 patients. And this trial also stopped early because they had better outcomes in the primary anastomosis group on secondary endpoints. Again, grand majority were Hinchey 3, highly selected patients. And what they found that overall the primary anastomosis group, so resection and anastomosis, was on average half an hour longer than the Hartman's procedure. And here what they did is they looked at the continuum of care for the full year, including the reversal. So this is with the reversal time. So the primary anastomosis itself was longer in the emergency setting. Overall, if you count both operations, the Hartman's procedure with its reversal was longer. And their main take home was the total number of complications was greater if you did a Hartman's and a reversal versus a primary anastomosis and a loop ileostomy reversal. The Diverti trial came next out of France, and this was published in the Journal of American College of Surgeons. This, again, highly selected group, only 100 patients in 7 hospitals in France over 4 years. So surgeons are very careful who they'll enter into such a trial. About 40% of the operations were performed overnight, and almost all the resections were in purulent peritonitis. 10% of patients crossed over from the primary anastomosis to the Hartmann's procedure because the surgeons felt more comfortable doing a Hartmann's procedure regardless of randomization. And what they found was overall operating room time was similar between the two groups, and they had comparable mortality and morbidity in both groups. Overall, the stoma reversal was higher with the primary resection and anastomosis. 95% of them were closed versus Hartmann's procedure. Only 65% of them were closed. And by the end of the trial, definitive stomas occurred in 35% of the Hartmann's group versus 4% of the primary anastomosis. So the main benefit they saw was less stomas on the long term. If you did the primary resection and anastomosis, we all know that a loop ileostomy is easier to close. So my research group looked at this question and we said, okay, there's tons of data, there's randomized data, there's cohort data, there's even meta-analysis of the randomized trials, but I prefer to show you what the individual data looked like so we can apply it to our practice. What's happening in the United States? This is using the nationwide inpatient sample. Last year, we queried it, and in about 500,000 patients, we found that overall, the rate of Hartmann's procedure compared to primary anastomosis in the complicated diverticulitis is slowly getting a little bit less. So a few percentage points less. Still more Hartmann's procedures being performed in the United States over primary anastomosis. And that looks a lot more like my practice rather than what I'm hearing at the podium many times and what I'm seeing in the literature, as we're still performing a lot of Hartmann's procedures, and maybe rightly so. So when we look at the literature, we understand now that it's a very select group of patients that are probably ideal for primary anastomosis. We need to know who they are. We need to pick them out in our practice. And it's predominantly really being used for localized peritonitis or Hinchey 3. Feculent peritonitis and organ failure are really the predictors of mortality, and we need to take that into consideration. The literature does show acceptable anastomotic leak rates, and the jury's still out whether you need to perform a primary diverting loop ileostomy or not. About a half of patients, if you're going to do a primary resection and anastomosis, will need splenic flexure mobilization. So that's something important to think about. Many of these randomized trials were performed with an open approach, and it is a bit of a longer operation. So now let's go to real life, because we don't live in a randomized controlled trial. I don't know about you, but most of my diverticulitis cases happen at night. I'm very happy when they do happen during the day. And these are the things I want us to think about in a bit more detail. Who's my patient and what are their comorbidities? What's the quality of the bowel? What's the environment of the abdominal cavity? And what's the utility of a diverting loop ileostomy in this emergency setting? So for the patient, what are their comorbidities? Are they immunosuppressed? Are they nutritionally depleted? Some patients, have perforated diverticulitis and it got worse at home. So they've been actually sick for a week before we see them. Some patients are admitted to the ward with just an abscess and then they perforate imminently on the floor. These are two very different patients. Is the patient a smoker? Most importantly, if I do perform a resection and an anastomosis, will my patient tolerate a leak if it were to occur, or would they die? Does the patient have organ failure at the beginning when I'm assessing them in the emergency room? Sometimes they don't at first, but once we induce anesthesia and we start working and we stir up the sepsis, they become hemodynamically unstable. So of course, we're all asking anesthesia, how's my patient doing now? Are they making urine? Are they on pressors? Because anesthesia doesn't always want to tell us these things. So we need to keep asking as we're operating and evaluating, can my patient tolerate a longer operation or not? Then the quality of the bowel. like I was saying, sometimes the patient already has a pelvic abscess and then their situation progresses into free perforation. Some patients present with an immediate free perforation. If there's a pelvic abscess or a lot of sepsis in near the distal colon, distal sigmoid colon, where it may have perforated in the upper rectum, we all know for a primary resection and anastomosis that we need to remove the entire sigmoid. Whereas if we're doing a Hartmann's, we're just going to remove the section that has the hole. So these are two very different operations. If I'm going in to just remove the hole, contain the sepsis, make a colostomy and get out, it's okay. Even I will probably transect in distal sigmoid and not go up to the upper rectum. But if I want to do the definitive operation in the emergency setting, we are going to mobilize upper rectum and we really need to transect at the upper rectum. Sometimes that upper rectum is rigid because of the sepsis in the abdominal cavity. And if the rectum's rigid, when you put that stapler across or when you try to sew to it, and you're not happy, that's a problem. You don't want to create a primary anastomosis like that. It's better to go in some sigmoid, even if that's thick and yucky, and you're going to leave a drain and, you're going to put up a colostomy. Another factor is you're going to want, if you're doing a primary resection anastomosis, you're going to want to go to supple proximal bowel, nice, healthy proximal bowel. How much descending colon does this patient have? Is it a little redundant? Or am I going to have to mobilize the splenic flexure? You don't want to do an anastomosis under tension just to avoid a Hartmann's procedure because your patient will leak. And so the patient's body habitus and the time of day, your assistance, and how the patient's doing. And also, if they're waiting to do 4 cases and they keep asking you every 10 minutes, are you going to finish? And then you still have to do a splenic flexure mobilization. That's something to consider as well. So I look and glance at the at the descending colon and see, am I going to have to mobilize splenic flexure or not? Also, when we're in a situation of sepsis, sometimes the mesentery gets inflamed and gets foreshortened. Well, that's not going to help for reach for creating an anastomosis. So again, we're going to look at the mesentery. We're going to see, is this going to be a very simple, straightforward operation, or is this very difficult because of the situation and it's better to just put up a colostomy? Next is the environment that my anastomosis will sit in. So is this a pelvis that's full of sepsis and I'm going to put my anastomosis in a chronic pelvic inflammatory cavity, and also the abdominal wall thickness. Sometimes you say, I'll just do a Hartmann's, it's easier, but then, your problem is the abdominal wall and bringing through a colostomy through that abdominal wall. And so these are other factors to consider. The diverting loop ileostomy, we love it when we do rectal cancer. The patient is bowel prepped and, it protects our anastomosis and it protects our patient from the clinical sequelae of leak. But here it's different. The bowel is often not prepped, and on-table lavage is not part of my practice and isn't very pragmatic. So when you do a diverting loop ileostomy, and in these trials, commonly you do the diverting loop ileostomy, but you still have a column of stool. So it's important to assess whether this is really necessary because it's not really full diversion. So for me, if it's a stable patient and the bowel ends were both healthy, it's a good and tested anastomosis, I don't always perform a diverting loop ileostomy, understanding that there's still a full column of stool, regardless whether I do a diverting loop ileostomy or not. So when we're trying to resist the Hartmann's and, push the needle a little bit towards adoption of primary section anastomosis, I think we need to consider, is this the right patient and the right circumstance? Do I have the right team on with me? I start with the plan and I keep reviewing throughout the case whether it's still a good plan, or perhaps we'll just do the Hartmann's and come back another day. When I'm preparing for the case, I have my patient marked, in all 4 quadrants if they're obese, or at least in both sides. So I'm prepared for a colostomy or an ileostomy. I really love the split leg table. It gives us access to the anus. So you can fire a circular stapler. If you are going to make an anastomosis, you can also attest your anastomosis, and you can stand between the legs if you're going to do a splenic flexure mobilization. I used to make fun of people who did extreme irrigation, but I'm a big adopter right now. I think a big part of, Hinchey 3 and 4 diverticulitis is really got to irrigate the abdomen out well. I literally use 10 liters of warm saline and make sure we've gotten through to all the pockets of pus. Again, as I was saying earlier, and I will harp on this point, is that we have to avoid the easy way out of doing a colocolic anastomosis. We can't leave any little bit of distal sigmoid. That will definitely increase the risk of recurrence for our patients. So if we are going to do a resection and primary anastomosis, we need to go to upper rectum. And that often involves mobilizing splenic flexure because we're going to take the sigmoid. So often you need to mobilize that splenic flexure. So liberal use of splenic flexure mobilization. Another thing is we know that this isn't cancer. And so, or hopefully we know before we go to the operating room that this isn't cancer. And something I advocate is a close colic resection, really staying very close to the colon wall. That way we avoid the impacting the ureter or the nerves for sexual and urinary function. Finally, I like a side-to-end anastomosis at times because sometimes within end-to-end, even though I am anastomosing to upper rectum, there's plenty of diverticula and I can't find a free spot to create a nice end-to-end anastomosis, and a side-to-end will avoid any diverticula. Laparoscopy has been used for primary resection and anastomosis in the emergency setting. Again, this is National Surgical Quality Improvement Program database data. So it is going to have some selection bias despite correcting for confounders, but better complication profile and mortality profile if you are able to do it laparoscopically and it's suitable for your patient. So a few words about doing a minimally invasive approach for these patients. I will just share with you a few video clips. So this is a patient with Hinchy 3 diverticulitis. And here's a diagnostic laparoscopy looking for the hole. And as you can see so far, it's all purulent peritonitis. So lateral mobilization, we identify the hole here and the area where the patient had perforated their bowel. You see the bowel's pretty supple. You're pressing on it, it's moving nicely. And the perforation was really contained in the abdominal wall and pelvic side wall. You see here the distal colon seems pretty supple and nice. So once that area is resected, we perform a splenic flexure mobilization, as you can see being done here. And again, very nice supple bowel. You see the inflamed bowel distally, and we pick our proximal resection margin, and we have plenty of length. The bowel is not very edematous and looks like it will create a nice anastomosis. We resect the affected area, and then a primary anastomosis is created. And again, you see it looks almost like an elective case if it wasn't for the beginning, and you see the pelvic cavity at the top over here where the inflammation had happened, but it's to the side, and a primary anastomosis is created and then tested, and it needs to look as good as it would in an elective case. Otherwise, I'm not doing the patient a service. So this looks very typical to an elective operation. I'm happy with this. And then we test the anastomosis with flexible sigmoidoscopy just to make sure that there's no air leak. And then it's your discretion. The data is not neither here nor there for diverting them. So if it wasn't for this cavity, looks pretty nice. Versus this case, where a patient again has peritonitis and perforated diverticulitis, but then there's all this stool, which is quite nauseating. So this is a patient with feculent peritonitis from a perforated diverticulitis. And you see the hole here causing the perforation causing the feculent peritonitis. And this is a mess. So first we clean up the mess. And we suction away and irrigate away. And you see the fibrin and stool between the bowel loops. You see how edematous things are here. You see this is the mesentery. This is where the inferior mesenteric artery would be. And it's just bathed in inflammation and pus and stool. And this is not what those studies were talking about. The grand majority did not look like this. And then, of course, you have to add and see how sick this patient is. This was a hemodynamically stable patient for the moment, and that's why laparoscopy was used. So suctioning and cleaning up, getting a lay of the land to see really how bad the sepsis is. And then here's what I mean about a close colic resection. So the hole is up at the top of the screen, and using an energy device, the sigmoid colon containing the perforation is being resected. And you see, normally if you're doing an elective case, you would be a little bit lower in the mesentery, even if it were benign disease. But here you are just at the colon wall. You don't want to be any more proximal on the mesentery, because you won't be able to identify ureter easily here. You won't be able to see the nerves easily here. Everything is inflamed and thickened. And if you stay right up at the colon wall, you're safe and you're removing the hole. This is the goal here, is just to remove the area containing the hole. Once we've done that, we need to find proximal and distal resection margins. And this is a case where we decided to do a laparoscopic Hartmann's. And so we're identifying proximal and distal resection margins. Here you see the proximal colon being cleared off. So this is not a case where I would want to do a primary resection in anastomosis. It's a very hostile and edematous bowel, and the whole abdominal cavity is full of stool and pus. We cleared off the bowel wall, and we're going to just staple across. And now the distal resection margin. Here you see we're still in sigmoid, and the distal resection margin is being cleared off using a nice energy device. And because this is not going to be a formal resection, a formal primary anastomosis, we don't need to go up to upper rectum. Actually, it's better to stay in sigmoid so that the next operation is easier, and the presacral plane and all that posterior plane is virgin, and we don't open it in the emergency setting. And then we staple off the distal sigmoid right here, and the perforation is in this stuff over here. And then finally, a lot of irrigation. I think that's one of the drawbacks of laparoscopy, but we need to really irrigate the abdomen out well and get rid of all the fibrin, pus, and stool to decrease the chance of interloop abscesses in the patient's recovery. And then finally, we bring out the nasty specimen. Here we go. And the abdominal cavity looks a lot better than when we started. So perforated diverticulitis is definitely challenging and fun, but we have to recognize it's a very heterogeneous disease, and every patient is different, and every case of sepsis is different. Primary resection and anastomosis can be performed, but we really have to select our cases, and I think the needle will continue to move, but very, very slowly. And we can employ a minimally invasive approach when it's appropriate and when we have the right expertise. Thanks again for having me.
Thank you. Thanks a lot. Thank you, Dr. Woodruff. It's very, it's like exciting. I like the videos that you have done surgery, reminding me of when we were in training together. So yeah, questions, please. Question from the audience. We have some questions from the audience for Dr. Alvarenga. There are two questions for you. The audience was asking if you were thinking of diversion in the case of obstruction, cancer obstruction, would you go for minimal invasive approach or laparotomy?
Thank you for your question. Yes, it's been very light publishing on minimally invasive approaches for emergent obstructions. I particularly have not performed. Oftentimes when you have a patient sick enough to undergo emergent surgery, is a high-grade obstruction. And oftentimes that, the difficulty of doing minimally invasive approaches because of the obstruction is a reality. So I usually do it open, but I do believe that if you have the right setting and the right tools, it's feasible. I would do it if I have the facility, but that has not been my experience so far. Usually it's open surgery for obstructive cancers.
Right. And if the obstructions is at the distal left-sided colon, what would be your choice of diversion? Which part of the colon would you prefer for diversion?
For the left side,
Yes.
you know, the literature from what I is pushing more for decompression only, to not burn bridges with, you know, possibilities of new adjuvant treatments. But honestly, the results are not that statistically significant. So if I go for an operation of obstructive left-sided mass and the tumor is resectable and there is no concerns for metastatic disease, it does make sense to remove that tumor if you can guarantee an oncological resection. And the literature is being on both sides. So my personal experience, whenever I check all those boxes, I tend to remove the tumor and divert.
Right. Thank you. And another question for you, Dr. Olenka. You said for the left side colon, you would do diversion. For the right side, it is recommended by literatures anyway. And for the right side colon, you prefer to perform like resection and primary anastomosis. How about the in the middle, like at the splenic flexure? What would you do? Would you choose to do the resection with anastomosis or diversion? Thank you.
For a proximal tumor, the splenic flexure tumor?
Right.
You know, when I have an splenic flexure tumor, my first consideration is to an extended resection. And I'm still tempted to do anastomosis for being a left-sided tumor. But again, I've done diversions only, resecting, doing a segmental extended resection and diverting when the degree of obstruction is severe. Remember, when you have all this distinction, it just, the rest of the colon is ischemic changes, right? So it's not good. It's not even about the mismatch. It's about the nature of the tissue. So when I have these situations, I've done endoleostomies and mucus fistulas for that matter, but I'm tended to do extended right colectomies versus segmental collections in non-emergent setting. That answers the question?
Yes, yes, nicely, thank you. And for Dr. Boutros, I'm not sure if you have a patient with perforated diverticulitis, and then in the ED, and then what would be your criteria or decision making of to do approach with laparoscopic approach or laparotomy, or you do approach all your patients laparoscopically first?
If they're hemodynamically unstable, I usually do not do laparoscopy. I find it's hard to justify. If they're hemodynamically unstable, I think we want to resuscitate them actively, get them on and off the table as soon as possible, and just control the sepsis. So that's the main determining factor for me. I won't lie, body habitus, you know, if they're really obese, I'm like, I don't know if I want to do an incision here. I really want to do a laparoscopy. I think it's better for them and better for me. But really hemodynamic state. And then once I have a very low threshold, it's not like elective surgery to convert. It's not a failure. So I put the camera in, and if I can't see anything, if it's, you know, we're lots of stool and I feel like we can't do a good operation, I convert right away. Or prior operations with a lot of scar tissue, we're in the emergency setting here. We're not going to lyse adhesions for several hours. That's kind of my priorities is number one, to get the patient out of sepsis. Number two, to do a primary resection and anastomosis if I can. And if I can do that much more rapidly open, I will have a low threshold to convert. I will do an open operation, but avoid the Hartmans for them if I think they're a good candidate. And number three, is a minimally invasive approach. So it's a little lower on my priority list when I'm seeing a patient with perforated diverticulitis in the emergency room.
Thank you. And if the patient presented with a high-grade fever and localized peritonitis, and the CAT scan showed small air bubbles outside of the colonic wall, like no major free air, what would you do?
I think I'd give them a go with conservative management. They just localized peritonitis, yes?
Right.
If they have good reserve and they're not immunosuppressed, I would give them a go with conservative management. I've seen it actually go very well with a close eye. This is somebody would be like checking on several times a day, making sure that they're okay. High fever tells me that they probably have a real perforation. They're going to form an abscess, at least. So I would monitor them closely, but give them a go at conservative management.
Right. This is the same if the air is leaking to the colonic mesentery. Is it the same decision that you would make to this patient, like conservatively, treated conservatively?
I mean, I have, but then when they do form an abscess, it's harder to manage because it'll probably be like not drainable in the mesentery. So low threshold, if they're not improving, then a low threshold to go to surgery.
I see. Thank you. Thanks. We're coming to the conclusion part now. So thank you to both Dr. Abarenka and Dr. Boudreaux for such an excellent and wonderful talk. Okay, and thank you all the audience for all the excellent questions. Many questions are similar, so I just wrapped up to one or two questions for all of you. So thanks to the ACS International Relations Committee and to let us Thailand chapter to host this first webinar, ACS IRC webinar. Thank you, and I will hand it to Jesse. Jesse. You're muted.
Sorry about that. Thank you, all three of you, for participating and presenting. As mentioned at the beginning of this webinar, these presentations have been recorded and will be posted on the ACS YouTube channel. You may also view past webinars on the ACS YouTube page under the Global Surgery playlist. I also wanted to highlight that this year residents can become a member of the American College of Surgeons for free this year. And lastly, if you have any questions or feedback about this presentation, please contact myself or any of the IRC staff, and the information is on the screen. Thank you everyone so much, and we hope you have a great day. Bye-bye.
Thank you. Thank you. Bye-bye.